This is Dr. Nicholas Tedesco DO, the Associate Program Director of the Good Samaritan Orthopedic Surgery Residency in Corvallis, Oregon. I'm here to present musculoskeletal oncology general considerations as part of my yearly lecture series that will supplement the formal didactic sections that we have. Disclosures as usual, I do own stock in RomTech, which is a orthopedic rehabilitation company. It has nothing to do with this presentation. So the first thing we'll talk about whenever we start into the field of oncology when it comes to tumors, there's always staging. So whenever there's a tumor, whether benign or malignant, there is a staging method out there. The whole point of staging is to help prognosticate and therefore help dictate treatment. So the first thing we start with is benign staging, which is dictated by the Musculoskeletal Tumor Society or the Eniking classification. These are Arabic numbers 1, 2, and 3, the ones that we know as our normal numerals. So a stage 1 is a latent benign tumor, stage 2 is a active benign tumor, and stage 3 is an aggressive benign tumor. So a latent tumor is one that's been there for a long time, not really doing anything. There's going to be no surrounding reactive zone on the MRI, and it has a relatively indolent course. An active lesion is one that may be painful or may be growing but isn't overtly destructive or rapidly progressive. An aggressive lesion, however, is. So you'll usually see either bone destruction or secondary invasion of bone, or the analogous one in the soft tissues is going to be a desmoid tumor where it intensively infiltrates and takes over anything in its path. Malignant staging prizes an amalgam of grading the tumor, which is a degree of differentiation and a degree of cellular division under the microscope, grading the tumor itself in terms of size and location, and grading the presence or absence of any metastases, whether local, regional, or distal. So the first staging that we have is, again, the MSTS or Eniking. These are now Roman numerals instead of the Arabic numerals. The malignant staging basically defines, is it low grade or is it high grade, and is it intra or extra compartmental, meaning is it bound by fascia or bone, or has it broken out of those planes? So stage 1 is a low-grade tumor. 1A means it stays intracompartmental. 1B means it is broken through a fascial plane, broken out of the periosteum, something like that. Stage 2 is going to be your high-grade tumors, again, intra or extracompartmental, and stage 3 is any metastasis, whether it's a skip metastasis in a bone tumor, a local regional lymph node metastasis, or a distant lung metastasis. The other side of that is the American Joint Commission of Cancers, or the AJCC staging, which is much more complex. It now takes into account the location of it, the size of it, the grade of it, presence or absence of METs, and the type of METs that it has. So for our purposes and for most testing purposes, they're going to talk about the extremities staging, but it is now for the first time ever broken up into extremities, mobile spine, pelvis, and sacrum. So for the extremities, stage 1, similar to the Eniking system, is a low-grade tumor. However, A and B has nothing to do with compartment, it has to do with size. Tumors less than or equal to 8 centimeters is A, greater than 8 is B. Same thing with stage 2, high grade, less than or greater than 8 centimeters. Stage 3 is the presence of a local regional skip metastasis. Stage 4 is distant mets, whether it's A to lung or B anywhere else. Lymph nodes, liver, brain, you name it. Previous staging was for bone sarcomas only. This is now going to be for soft tissue sarcomas only. Again, it now breaks it up into location, trunk and extremities, retroperitoneum, head and neck, or visceral sarcomas. This again is much more complex but much more prognostic than previous AJCC staging systems, and probably more than the Eniking staging system as well. So again, we'll talk about the extremities for our purposes and for testing purposes. And so stage 1, again, low grade, but now we're talking about size is 5 centimeters is the cutoff. Stage 2 is high grade, less than 5 centimeters. Stage 3 is high grade, greater than 5 centimeters. A is 5 to 10 centimeters, and B is greater than 10 centimeters. Stage 4 is, again, presence of any metastasis regardless of location or distance. The next thing we need to talk about is going to be the imaging of musculoskeletal tumors. This is crucial to diagnosis, preoperative planning, determining anatomic boundaries, talking to patients about surgery, all of that stuff. So the first thing we talk about is what's called the reactive zone, which is the edema, neovascularity, and inflammation that attempts to quote-unquote wall off or the body responding to the tumor. It's best seen obviously on the MRI. So here's a good example on the left there where you have the tumor, but then you have this infiltrative, wispy, high signal intensity junk around the tumor. That's the reactive zone. A benign tumor will have no tumor beyond the pseudocapsule directly around the tumor, which is defined as not a real capsule. So the body has not created a new cellular layer to wall this off, but instead it's sort of the fibrous debris, the smashed down tissue from the compression of the tumor that immediately surrounds it that does sort of distinguish normal tissue from tumor. There's a limited reactive zone in benign tumors, usually because, again, they tend not to be nearly as aggressive or incite as much of an immune response. Malignant tumors, however, will have an extensive reactive zone, and they will have satellite cells, which is tumor beyond that pseudocapsule, which usually spreads into the reactive zone, which is what the reactive zone is responding to. The other thing we talk about on imaging in terms of signs of aggressiveness is periosteal reaction, presence or absence of it. You can have soft tissue tumors that secondarily invade bone and will incite a periosteal reaction, and you can have primary bone tumors that will incite a periosteal reaction. It's essentially the building of new bone in response to injury, infection, tumor, whatever irritates the periosteum. So the first one we talk about is a lamellar periosteal reaction. The other common name for this is onion skinning. This is essentially periods of growth, relative arrest of that growth, followed by another period of growth where the bone tries to catch up with it and sort of does, but then it breaks out again. And so then the bone has to respond again, and then it breaks out again. So you get this layering effect of that periosteal reaction. The next one is the spiculated periosteal reaction, or more commonly referred to as the hair-on-end appearance. This occurs as a result of stretch of Volkmann's vessels, if you recall those from histology, in the cortical bone. As that gets stretched from compression and growth of the tumor, it incites this linear spiculated periosteal reaction orthogonal to the surface of the bone. The final thing is what's known as a Codman's triangle. What a Codman's triangle is a triangular new bone formation of periosteal reaction. It can be mature or immature. This is an image of an immature reaction, and you can see it just looks like a triangle sticking off the side of the bone, and the reason it's a triangle is because where that gets truncated distally there is a large tumor. So essentially, as that tumor breaks through the bone, it pushes out on the periosteum, and so it starts to elevate it. So you get periosteal new bone formation in that tiny triangular portion where it's pulled away from the bone, but distally, the tumor is completely smashed against the periosteum, so there is no enough time for the bone to react and build new bone there before it gets overtaken by tumor. When it's mature, it just looks like normal cortical bone. A mature periosteal reaction is usually a sign of a very long-standing indolent process. So either a secondary involvement of bone from a benign soft tissue tumor that's been compressing the bone for years, or a relatively benign bone tumor that perhaps grew but then stopped growing, or the bone did win and wall it off. The next thing we have to talk about whenever we're looking at an x-ray is what's called Enneking's 4 questions. So Bill Enneking always asked these 4 questions with every x-ray he looked at, which helped decide a differential diagnosis and help you figure out what's going on and then therefore what the next step may be. So the first question you always have to ask yourself is what's the location of the lesion? And that means both the location in the body as well as the location in the bone. So is this axial? Is it appendicular? And then in the bone, is it epiphyseal, metaphyseal, metadiaphyseal, diaphyseal, periosteal? All of those things help figure out what this is because many tumors do very characteristic things in very characteristic areas of bone. That helps you whittle down the differential diagnosis. The next question is what is the lesion doing to the bone? Meaning, is it eating it alive? Is it blowing it out? Is it expanding it? Is it doing nothing? Is it just there? All of those things. The next thing is what is the bone doing to the lesion? Is it walling it off? Is it creating a periosteal reaction? What exactly is the bone doing to respond to this thing? The last thing is, are there any characteristic matrix clues in the tissues of origin, bony, fibrous, or cartilaginous? And we'll talk about that in a little bit. Additionally, I've added sort of a fifth question that most musculoskeletal oncologists always ask as well, is what's the age of the patient? Age matters. Certain tumors show up at certain age brackets. Obviously, that's never a 100% grant, but it's one of those things that, again, can help you figure out what this might be and therefore what needs to be done about it. So again, getting back to the imaging, we talk about lytic versus blastic. So this is, what is the tumor doing to the bone? Is it eating it away, or is it inciting the bone to build more bone? Or is it creating calcium deposition? So here are some images on the left with a lytic lesion that is eating the bone alive up top. And down below, if you look at the pelvis and the spine there, a couple of them are the so-called ivory vertebrae, where they're incredibly bright white. These are blastic lesions. They're inciting bone formation and calcium deposition, so they're whiter on imaging than darker. The next thing we want to describe, central versus eccentric. Central essentially means it's confined and bound within the bone marrow cavity or the medullary space, does not involve the cortex. Eccentric means it can or may or does, but it's, again, different. Different things tend to be central, other things tend to be eccentric. Helps you whittle down the diagnosis. Presence or absence of what's called a reactive rim of bone. So you can see this white rim of bone surrounding this. So this is a tumor that seems aggressive, that is crossing the physeal plate in this child, yet it's been completely walled off by bone. So again, this is a sign of something that may have been aggressive, but the bone caught up to it, or it's very indolent, very slow growing, so it does slowly overtake things, but the bone then wins and walls it off, then it blows out again, things like that. But again, it suggests something more along the lines of something benign rather than malignant, although there are malignant things that can still have a reactive rim of bone, but it's another thing to comment on when you're looking at these images. The next thing is the term geographic. Geographic basically means you can outline it, or you can draw a pencil line around this entire thing and know exactly where the lesion in the bone is. So another name for this is called a narrow zone of transition. So the zone of transition from abnormal to normal is very abrupt and narrow. You can outline this thing, you can see exactly where it begins and ends. Moth-eaten, however, is a wide zone of transition. Although you can clearly see the abnormal bone here and the moth-eaten characteristic of it, how it looks like, an old tattered piece of cloth, what you have here is a very wide zone of transition. You can't tell exactly where the abnormal bone ends and normal bone begins. The last one is permeative. Again, it's a similar finding, not quite moth-eaten. You do have a lytic lesion here, but you see this big periosteal reaction stretching up and down the entire bone, even though the lesion is very centralized there. So this is a permeative lesion that you don't know exactly where this lesion started and stopped. You can see where perhaps it's the most destructive, but you don't know where all it goes to without further imaging here. So again, this is a wide zone of transition. Now getting back to the matrix that we just alluded to earlier, this is one of those things where we talk about what is being built within the lesion. That's the matrix. What is the extracellular component of the lesion? Ground glass is very characteristic for fibrous lesions and even more specifically fibrous dysplasia. Many other fibrous lesions will not necessarily appear ground glass. Here you can see that. It's this sort of, they call it the smudged or shower door appearance, where it's not purely lytic, but it's certainly not blastic, and it almost looks like you took the medullary canal that was a pencil drawing and rubbed your finger across it and just smudged it all. So you lose the fine detail, but there's still a little bit of that calcium in there. That's the ground glass appearance of fibrous dysplasia. Cartilage matrix is described as arcs and rings, stippled calcification, popcorn ball, smoke in the chimney, things like that, that will describe sort of how that looks. This is a classic example of that, where you have all of these arcs of calcium, stippling, flocculations. This is without a doubt cartilage matrix. The last thing is bone. You can have mature bone or you can have immature bone or osteoid formation. So here is mature bone matrix. You can see very densely sclerotic, coming off of the proximal humerus and the distal glenoid, and it looks like normal bone. It's incredibly dense, incredibly sclerotic, no obvious new bone formation, periosteal reaction, that sort of thing. So this is chronic, this is mature. Immature or osteoid matrix is the flip side of that. This is described as cloud-like calcification. You see these sort of stippling and arcs and rings associated with chondral deposition. However, the calcium within the chondral lesions tends to be much more dense. So again, if we go back to that image, you can see very clearly it's much different than the osteoid cloud-like formation. So in terms of that zone of transition, there is a classification for that known as the Lodwick classification that tries to define, narrow versus wide, geographic versus permeative. So type 1 is the geographic narrow margin of transition. 1A is a well-defined sclerotic rim of bone. So a Brody's abscess, non-ossifying fibroma, these are classic examples of that. 1B is well-defined but no sclerotic margin. So multiple myeloma, a lytic punched-out lesion, very clear where the lesion is, where it stops and starts, but there's no sclerotic margin. And 1C is a wide zone of transition, but delineation between normal and pathologic bone is still identifiable. The classic example of this is fibrous dysplasia. Again, you can see the fibrous dysplasia and that smudged out ground glass phenomenon blending in with the normal bone marrow, but you can clearly tell kind of where that fibrous dysplasia is and normal bone marrow is. Type 2 is the advancing margin, so either geographic on one side and permeative on the other, such as a secondary chondrosarcoma or some other lesion that has flipped the switch and gone from benign to malignant. Or the other type of type 2 is moth-eaten. So two very different things, but they have a wide zone of transition, at least at some point in the lesion. Type 3 is those permeative lesions, where you have what appears to be a lesion, but then what appears to be abnormal bone or periosteal reaction in a much wider zone than you would have expected based on the appearance of the lesion. The final margin is what's known as the invisible margin. So it's not even seen on the x-ray. There's no periosteal reaction, no obvious bone destruction or bone lesion. And then you get an MRI and lo and behold, there's a huge tumor in there. Invisible margins tend to be bad. Ewing sarcoma is the classic one for creating this type of phenomenon. So now that we've defined the terms that we use and the things we're looking for on the imaging, how do we use imaging? Well, skeletal survey is one of the things that we use when we're working up a tumor. This essentially looks at the pelvis, the skull, the entire spine, and the at least proximal extremities and sometimes distal extremities when indicated. It's x-rays of all of these areas, and what it's designed to do is pick up purely lytic processes when they're suspected. And that's because a bone scan relies on osteoblastic activity. If you have a purely lytic process, there is no osteoblastic activity, and a bone scan will be negative falsely. So this will help pick all of that up. Multiple myeloma is the classic example of a purely lytic process that may be cold on bone scan that will show up very easily on a skeletal survey. MRI is the next thing. So the first thing you want to order when you're ordering an MRI is a tumor protocol, which will include much more spin echo sequences as opposed to gradient echo sequences. Spin echo sequences, we know what tissues look like what on that. Gradient echoes are at the behest of the radiology tech to put in different parameters, which can be different from tech to tech. So you can't comment on the actual tissue type seen on those images. So in terms of diagnosis, you want to order tumor protocol and get a true T1 and a true T2 imaging. You always want to include IV gadolinium unless there's some medical contraindication to that. The gadolinium will help determine cystic versus solid. It will help determine the full extent of the tumor and anatomical boundaries and derivation. So on T1, fat signal is bright. On T2, water signal is bright. However, on a true T2, fat signal is also bright, which is very confusing. So normally when you're looking at a T2, it's actually going to be a fat-saturated T2 to really bring out that water signal as opposed to fat. So on T1, gadolinium, fat, hemorrhage, and exudate will all be bright on that image sequence. What does that mean? It just means higher signal intensity compared to skeletal muscle. So all of those things may still be darker than fat, but they are brighter than skeletal muscle. So we're always talking about skeletal muscle when we are using the terms bright or dark or hyperintense or hypointense. On T2, cartilage, edema, joint fluid, transudate, active tumor, and blood will be bright. What will be dark is fibrous tissue, hemosiderin, necrosis, and calcium. So whether that's bone, dystrophic calcification, whatever the case may be, so you have to correlate that with your x-rays. If there's jet black stuff on the T2 and nothing seen on the x-ray, then it's not calcium deposition. Now you've got to be thinking hemosiderin, something else that helps, again, whittle down your differential diagnosis without having to go through an invasive biopsy. So understanding the signal sequences, understanding what's bright, what's dark, how to utilize gadolinium, and what signal sequences you need is crucial to coming up with a useful tool for diagnosis and management of musculoskeletal tumors. CT scan is advanced imaging and cross-sectional imaging that's used to characterize typically bony lesions better than soft tissue. It can be used to assess impending or pathologic fracture. There's now some data that uses CT-based assessments of stress on the bone to determine if an impending pathologic fracture is at risk for a pathologic fracture, but these are still sort of in the experimental range. This is the modality of choice for suspected osteoid osteoma to find that small little nidus buried within the densely calcified tissue. And that's because on an MRI, there will be so much edema in this area, either you won't see the small nidus or you'll confuse it for either a fracture or a sarcoma. So it becomes very confusing on an MRI. If you're thinking osteoid osteoma, you want to get a CT scan. You can also use a CT scan for a full skeletal survey rather than x-rays. The advantage to it is it's much faster and it gives you cross-sectional imaging, but the big disadvantage is it's much more radiation. Next thing we talked about earlier is the bone scan that we use either or with the skeletal survey rather than and. So the bone scan is when you're thinking about a blastic process or something that is responding in the bone with osteoblasts. So this is where you're going to try to detect metastatic disease, polyfocal disease, or polyostotic disease. Essentially what this uses is technetium-99, and that localizes to the osteocytes and osteoblasts. There's a single phase scan, which is generally used for orthopedic oncology, or the triple phase scan, which is generally used to help differentiate infections within the skeleton. Another version of the bone scan is the tagged WBC scan, using either indium-111 or technetium-99 that essentially gets tagged to the patient's white blood cells. So they get a blood draw, they spin down the blood, they take out the white blood cells, they attach these to the cells, and they re-inject those cells into the body to see where and how they localize to tissues. Again, this is much better for infection or inflammatory processes as opposed to tumor, but it can be helpful. A SPECT CT is a version of this, especially when you're looking for things like an osteoporotic spine fracture, a subtle fracture or metastasis that you're not sure if it exists or you're having trouble detecting, but your index of suspicion is high. That's when this can be useful. Positron emission tomography, or PET scan, uses a radioactive labeled glucose molecule to detect metabolic activity in the body. The heart and the brain are very metabolically active, so they tend to light up. So if you're concerned for pericardial metastasis or brain metastasis, this is a poor choice, and those will need probably MRI or some other imaging. However, when you're looking for distal, peripheral, or organ metastases, this can be very helpful. Essentially, every cell in our body uses glucose for energy, but metabolically active tissues uptake much more of that. And so the uptake ratio and degree of metabolically active tissues is detectable by having much more of this positron-emitted radioactively labeled glucose showing up in those tissues. So this is how you differentiate from things going on. This is not going to be specific to tumor. It can be inflammatory, it can be arthritic, it can be infection, it can be injury, it can be all kinds of other things, but it will point you in the direction that says, hey, this needs further imaging and workup of this particular area. So now we're through the imaging. We still don't know exactly what we have. Next step is going to be biopsy. So what do you want to biopsy? Well, heterogeneous masses that are concerning, things greater than 5 centimeters that aren't obvious lipomas on advanced imaging. And the area you want to go after is the highest appearing grade of that lesion, which is going to be the brightest spot on the T2 STIR MRI or the soft tissue extension of an intramedullary lesion. You also want to scour those images carefully because any central necrosis or fluid collections or hemorrhage, there's not going to be live cells in there that you're going to get a meaningful diagnosis from. So you want to get the parts that are enhancing after gadolinium. The types of biopsy are excisional, incisional, or needle biopsies. And when it comes to needle, you talk about core or fine needle aspiration biopsy. You should complete staging prior to biopsy. And the reason is because if you stage them and there's tumor all over the place, you may need to biopsy a metastatic lesion in additional to the primary, or it may not be clear what the primary actually is. And so then you may change to biopsy the most accessible area with the least amount of anatomy to damage. If you're doing an open biopsy, either incisional or excisional, you always want to use a longitudinal incision with respect to the extremity. The incision is considered contaminated with tumor, so when you do a definitive tumor resection, the whole incision with a wide margin has to come out. If you go transverse across the extremity, you will then create a nearly circumferential incision that has to be made, which can lead to major marginal necrosis of the skin because of the proximal to distal blood flow in the skin. You want to avoid neurovascular structures, or else they're considered contaminated. You need vigorous hemostasis because the hematoma that forms afterwards is considered contaminated, so anywhere it spreads is going to have to come out. And you want to avoid violation of other compartments, other anatomy that's not involved with tumor, or now that's considered contaminated and will ultimately need to come out. So you must be very careful and vigorous and diligent with biopsies. You never probe the wound or the lesion or pass point. So you don't stick things in to feel around and see where the margins and the edges are, or you're already poking into normal anatomy. You don't want to violate the subcutaneous fascia if the tumor is superficial to that fascia. You never want to violate another muscular compartment, or if you're in the bone going into 3 different muscular compartments, you need to know your anatomy. You want to biopsy the edge of the tumor and the pseudocapsule, again, because that necrotic center is of no help. Dead tissue is not diagnosable. And then finally, these principles apply for any extremity lesion. Even if it's a presumed abscess, lipoma, a ganglion cyst, you never know if you've got that diagnosis right or not. And so just in case, you want to adhere to these same oncologic principles to not burn any bridges if additional things need to be done. So here's an example of the incision that you should make longitudinally, and again, an example of the wide ellipse that needs to be made around that previous biopsy tract during definitive resection. So if you take that wide ellipse, again, and turn that transversely, it's extensive. It's very morbid. It's difficult to stretch that skin. You get marginal necrosis. A lot of problems can happen. The other thing is all of our muscular and skeletal compartments are oriented longitudinally. So it makes it very easy when you do that transversely to contaminate multiple compartments rather than just the one that has the tumor in it. The biopsy should also be made where the definitive resection would take place. So you don't want to do a dorsal approach for a biopsy and then a volar approach for the resection. And so that's why if you're not sure, then it's always best to consult an orthopedic oncologist or send the patient outright. The biopsy tract needs to come out with the exception of a needle biopsy as long as radiation is going to be done to that wound afterwards. So again, we talked about earlier briefly core needle biopsy versus fine needle aspiration. A core needle biopsy is a large bore needle taking a large chunk of tissue, which is great for sarcoma diagnosis. Fine needle aspiration is a small core needle that you just stick into the tumor and aspirate, and whatever you happen to get out of that, you then plate. The problem with fine needle aspirations is you tend to get individual cells and only a few of them. One of the most important parts of diagnosis of a soft tissue or bony sarcoma is not just the individual cells, but the overall growth and architecture and morphology of the entire tumor. So a fine needle aspiration is never indicated for workup and management of a sarcoma. It must be a core needle biopsy to see that ultrastructure, and that architecture. When it comes time to surgery, in terms of resection, and this goes along with some of the biopsy principles, so intralesional, marginal, wide, or radical. An intralesional resection is where you actually go into the tumor and just scoop it out. So this would be the incisional biopsy. You make an incision, you go in there, you take a sample of the tumor, you don't take out the whole tumor, close it back up. A marginal resection hugs that pseudocapsule boundary. So you probably leave a few cells behind, and in many benign tissues that's not a problem, but that would also be considered an incisional biopsy or an excisional biopsy depending on what type of tumor it is. A wide resection is where you now go into normal tissue surrounding the lesion to make sure you get the entire lesion and all of its satellite cells. This would be the true full excisional biopsy. A radical resection is defined as taking out the entire compartment of that particular involvement. So if it's in the anterior compartment, it would mean resecting the entire quadriceps and extensor mechanism of the leg. If it's in the femur, it would be doing a total femur resection and replacement. If you just do a distal femur resection, that would be considered a wide surgical margin, not radical. So now we're through surgery, and we've got to talk about adjuncts, either to that surgery or to overall tumor management. So the first thing is radiation therapy. It improves local control of many tumors, but it's questionable what effect it has on overall survival or distant metastatic spread. It's also used for pain control and palliative debulking in unresectable tumors. It's given either in the adjuvant, meaning after surgery, or neoadjuvant phases before surgery. If it's given adjuvant, higher doses need to be given and a wider margin needs to be hit because of all of the contamination that surgery creates, that postoperative hematoma, all of those things we talked about with the biopsy. The advantage to doing it in the adjuvant setting are that you're doing this after the wound has healed. So there tends not to be any wound-related issues, but because the dose is higher, you tend to get more fibrosis, adhesions, edema, arthritis, fractures, other things caused by the radiation. When you do it in the neoadjuvant phase, narrower zones can be hit, lower doses can be used, but because of the damage to the tissue, and then you go and cut into it for surgery, there's a much higher risk of wound complications. And by much higher, I mean 30 to 50%. So it is substantial. There are constantly studies ongoing to try and figure this out and try and help this out, but it's rough. The other thing is it never really heals well. I've seen patients that have been open 3 years later after their surgery still not healed. So this is a legitimate problem and concern with neoadjuvant radiation therapy. Definitive radiation is considered radiation given with no plans for surgery. So usually that's in the palliative phase, meaning it's an unresectable tumor, or we've already resected it, there's a massive recurrence in the setting of metastatic spread, and we know there's no hope for cure. At this point, we're radiating it just for pain control, debulking measures, things like that. These are very high doses, so as you can imagine, much larger long-term risks and complications, but again, given in the palliative setting, we're usually not that worried about long-term toxicity. Common types of radiation therapy used, IMRT or intensity modulated radiation therapy, is a computer-controlled delivery of the radiation beam. The net effect is to concentrate a high dose on the tumor while minimizing the dose to the surrounding tissues. So that's by either controlling the penetrance of the beam and when it hits its maximal excitability, and or controlling how it shoots the tumor from multiple directions. That way it hits the tumor every time, but it's different soft tissue it's going through each time to relatively spare the soft tissues around it. Stereotactic body radiation therapy, or SBRT, is another way of really refining that radiation and really hugging the margins of the tumor. This is the gamma knife or cyber knife, things that are used in spinal, central nervous system, that sort of thing, where the stakes are high and no collateral damage can happen. Proton beam therapy is a relatively newer therapy that's come out that allows you to precisely localize the radiation dosage. You can control the excitability of that beam so that it enters the soft tissues at a low excitability, hits the tumor at its maximal excitability, and then fizzles out immediately thereafter. Again, the whole point is to minimize the collateral damage around the tumor and maximize the ability to deliver this to the tumor. Unfortunately, studies have shown that this hasn't decreased complications or increased effectiveness of the radiation with respect to the tumor, but it's one of those ongoing areas of study. Brachytherapy is delivery of radiation directly to the wound. So immediately after surgery, you close it up, and then the radiation oncologist comes in, inserts these catheters percutaneously, and then for several days postoperatively will flood radioactive tissue through that. You can only deliver a certain amount of dose to this, especially because it's a fresh, new active wound, or else it will never heal. So its uses are limited to maybe a postoperative boost or something like that. The other problem with this is the patient is now completely radioactive and they need this substance, so they can't have visitors. It's very difficult to isolate them, so a lot of fiddle factor with this, and as a result it has fallen generally out of use with a few exceptions. So chemotherapy now as the other adjunct, same thing as radiation therapy, can be given adjuvant or neoadjuvant. When it's given adjuvant, after surgery, neoadjuvant, or another word for it is induction chemotherapy, is given prior to surgery. Definitive chemotherapy, same thing, given without surgery. So that's not in the curative intent, that's more for palliative control, with the exception of leukemias, where those are chemotherapy-only diseases. This is used for systemic control, whereas radiation therapy is used for the local control. It's also used to improve survival in osteosarcoma, Ewing sarcoma, some large high-grade soft tissue sarcomas, and fibrosarcoma of bone. So even in those cases where there isn't distant metastatic spread, survival has been greatly affected and improved by the advent of chemotherapy addition to those diseases. It can be given intravenous or intraarterial. There are also now some oral drugs and things like that, especially for palliative medications. Typically, this does require inpatient admission because of the route of administration, as well as the significant side effects seen with these. And it's often supplemented with a granulocyte macrophage colony stimulating factor because of bone marrow suppression, depending on what you're using. So here are some common chemotherapy agents used in the sarcoma world. These have been tested on, and so it's good to know what these are. Doxorubicin or adriamycin is probably the most common and the most commonly tested because it has a very common and very deadly side effect, which is cardiomyopathy. It's a non-reversible congestive heart failure cardiomyopathy, and therefore if patients do actually get this, they end up on a heart transplant list. As a result, there are lifetime limits on how much adriamycin you can get. So if you get it once, everything's going well, 5 years later you relapse, you can't get it again. So the way it's typically tested is you're considering starting a patient on adriamycin or doxorubicin. What do you need to do? The answer is get a baseline echo because you want to see where their heart is now. If they're already in heart failure, then you're never going to know if you happen to get one after surgery, if that's new, if that's old, if it's due to the drug, if it's pre-existing, all of those things. You need to answer that question first as a baseline to then get echoes down the line to know if their heart is being affected by this drug. Ifosfamide is another one. Its side effects are usually kidney or hemorrhagic cystitis. Because of the hemorrhagic cystitis, and that can be significant, it's typically given with Mesna to help prevent that. Cisplatin is another one, and its big thing is going to be deafness and nephrotoxicity. So ototoxicity, nephrotoxicity. So you want a baseline renal function on all of those patients. You want an audiology exam as well. Methotrexate inhibits folate synthesis. The big thing with this is going to be neutropenia. Methotrexate and other folate inhibitors were sort of the first chemotherapy drugs on the market used in leukemia specifically because of its suppression of white blood cell formation. So neutropenia and then subsequent infections are the big issue with high-dose methotrexate. Imatinib or Gleevec is one of the most common tyrosine kinase inhibitors. Its big thing, just like doxorubicin, is going to be CHF and cardiomyopathy. So same sort of thing, baseline echo, follow them with echoes as time goes along. So now getting back to surgery adjuncts. So those are the adjuncts for the overall management of the tumor, but there are also adjuncts that you can use in surgery, which essentially the other name for this is a curettage expander. These are used when you're curetting a tumor out of bone, but it's an aggressive tumor, maybe even a malignant one, with a high propensity to come back. So you want to enhance your kill margin without having to do a wide resection that could be mutilating or debilitating for the patient. So what you do is after your curettage, you take out a high-speed burr and burr out that entire cavity to get a little bit of a wider margin and get through all of the undulations and unevenness inside that cavity. Then you want to flood that cavity with one of these things that will help kill any remaining cells in the lining of that cavity and immediately around it. So that's going to be chemical things like phenol or ethanol. It's going to be heat or cold, cryotherapy, or the gas plasma argon beam. Bovie and Aquamanus can be used, although they tend not to be strong and powerful enough or complete enough to really use that, but they can be used in limited environments. And then finally, phosphorus P32 radionuclide, which you can place into the area itself, or some people have even done injections into the knee for PVNS or tenosynovial giant cell tumor, that sort of thing. So these are just adjuncts that help kill more cells than your surgery otherwise would in an effort to avoid a massive mutilating surgery that may be worse than the disease itself. So what can you do as a general orthopedic surgeon? First thing, get a good history and physical. Include cancer history, family history of cancer, musculoskeletal syndromes that may put them at risk for cancers, their last PAP, pelvic exam or prostate exam for men, their last PSA level, colonoscopy, mammogram. All of those questions need to be asked to help determine what you might be looking at or what they might be at risk for. You want to get a plain radiograph of the area in question, even if it's a soft tissue tumor, to again look for secondary bone involvement, matrix characteristics even in the soft tissue tumor that can give it away, and then advanced imaging from the joint above to the joint below for any additional questions that need to be answered. You want to treat known METs with impending or pathologic fracture, with a nail, with fixation, with whatever you need to do, depending on diagnosis, depending on stage, depending on prognosis. You can excise known lipomas or very small superficial lesions using appropriate oncologic principles, and you can excise skin lesions using these same principles. Anything beyond this, you should probably consult an orthopedic oncologist. So when should you refer? If there's an extremity tumor that you're just not comfortable with, it could be a lipoma, but you're not comfortable with doing that. Fine, send it. That's what we're here for. If the imaging is suspicious, but you're not sure of the further workup or what we do next or how to biopsy this, send it along. If bony mets are found on a solid organ tumor workup, so these are the first mets, we didn't know they had them before, maybe their prognosis is a little bit different. If it's isolated mets and certain diseases, resection may actually be the answer rather than the old adage of, quote, just throw a nail down it. So send that along just for consultation and evaluation. The next thing is biopsy of an extremity tumor is needed, and you're not comfortable with that or don't know it or don't know where the definitive resection will take place, ship it on. If there's a desire to remove the tumor and you know it's not something you do or you're not comfortable with, send it to us. And if it needs further workup that you're just not sure what needs to be ordered next, send it along. Not a problem. Again, that's what we are here for. And the whole reason you want to refer that out is because of this quote-unquote whoops surgery, or what's called an unplanned resection. An unplanned resection isn't necessarily a resection per se. It could be a poor biopsy technique where multiple compartments or neurovascular bundles are contaminated. It could be failure to adhere to oncological surgical principles that are going to burn bridges with a subsequent surgery. And it could be a misdiagnosis entirely with an inappropriate procedure done, something like a nail thrown down a pathologic fracture in a patient with a history of breast cancer, but they have no other mets, and then it turns out the remings are positive for chondrosarcoma. So the wrong procedure was done for that. Get that on to us. So what can you do if you run into that trouble where you've already committed, you're already in surgery, and you're like, uh-oh, I'm in an environment where I'm not comfortable. This is a tumor. This was not what I expected, etc. First thing, get a frozen section. Take a sample of whatever it is you're looking at and what you're doing. Send it to the pathologist immediately. Fresh, frozen. Do not put it in formalin. And sit there and wait. Pack the wound off and just hold off until they tell you what they think they've got. Stop surgery immediately if need be. Obtain hemostasis. Again, you want to limit any hematoma that's going to happen afterwards. So cauterize everything, even stick tie larger vessels if you need to. Plug bone windows with PMMA. So if you're going in to curette what you think is just a simple bone cyst, turns out it's live tumor in there and you're really worried about it, but now it's bleeding like crazy and you don't want all of that tumor to leak out into the surrounding tissues, plug it up with PMMA. You want to close the wound immediately and splint or traction as needed if it's an unstable bone or joint. So for instance, I've seen patients that go in for a total knee replacement with a presumed hypertrophic osteoarthritis. They get in there, they burn through 4 saws trying to cut through the distal femur, so they send a sample of the bone and it turns out to be osteosarcoma. Stop the surgery, leave them with no knee joint, that's totally fine, splint them and send them. Instead, I've seen where physicians will actually complete the total knee because they're already in there, which then contaminates much more tissue, creates many more problems, and now that patient is for sure relegated to an above-knee amputation. So you need to be very careful with that, and don't forget it's okay to leave someone with an unfixed fracture or an already resected bone. Another example is where people will start reaming an acetabulum for a total hip replacement, and it's almost like reaming soft tissue rather than bone. And so they say, what's going on here? Send it for a sample, and then it turns out to be tumor, but they still put a total hip replacement in. Don't do that. Leave them with basically a temporary girdle stone, close it up, minimize any additional damage, and then ship it along to us. Not a big deal. So top testing facts to review. A lot of this is old, but some of this is still very, very pertinent and commonly tested. The most common site of metastasis from bone and soft tissue sarcomas is the lungs by far. The next most common is lymph nodes, and the next most common is other bone. The most common low-grade bone sarcomas are chondrosarcoma, parosteal osteosarcoma, adamantinoma, and chordoma. The most common high-grade sarcomas are osteosarcoma, Ewing sarcoma, and undifferentiated pleomorphic sarcoma. The order of importance of prognostic factors in bone tumor staging is number 1, are there already metastases at presentation? Number 2, is there discontinuous tumor, which is essentially a skip metastasis? What's the grade of the tumor, and what is the size of the tumor? A high rate of false negative results occur with bone scans in multiple myeloma. I wrote here et al. Because, again, purely lytic processes, so educating yourself on what those may be when you're suspicious of that diagnosis or have that diagnosis and you need to fully stage them, you don't want to get a bone scan. Instead, you want to get a skeletal survey. The order of importance of prognostic factors in soft tissue tumor staging is presence of metastases, grade, size. They used to think and depth, but we've now taken this out. So the new AJCC staging does not take that into consideration. Basically, size seems to be all that matters. And the reason we thought depth matters as we reevaluated this data is because deep tissue tumors tend to present at a much larger size because they're found later versus a subcutaneous one that you can find very early on and feel very early on. The RB tumor suppressor gene is associated with osteosarcoma. There are some other genes as well, including OCT4, and RB stands for retinoblastoma, so obviously it's present in other tumors as well. EXT1, 2, and 3 are the tumor suppressor genes associated with hereditary multiple exostoses. Ewing sarcoma and primitive neuroectodermal tumor are sort of the same family of tumors, probably the same tumor. They tend to have a characteristic chromosomal translocation of 1122. However, that's only present in about 85% of those. The EWS-ERG translocation on chromosome 2122 is the other that's present in about 10%, and 5% are actually translocation negative. Synovial sarcoma has a characteristic chromosomal translocation of X18. The majority of these topics listed here we're going to talk about in other lectures, but in terms of general musculoskeletal oncology, in terms of preparing for your boards and your OITE exams, these are the top testing facts. Additionally, chemotherapy drugs tend to induce programmed cell death or apoptosis. I wrote here sort of, and that's because that's the typical cytotoxic chemotherapy that we talk about. But there are many other chemotherapy measures out there that work in very different mechanisms and aren't necessarily designed to induce apoptosis. Radiation therapy induces DNA damage by creation of free radicals, so oxygen is a prerequisite in the environment for radiation. Aspiration and injection is used for select benign bone lesions, unicameral bone cysts, and eosinophilic granuloma. And so it depends on what you're injecting, what you're doing, but a lot of times cortisone can be helpful in some of these. Some of this is controversial, especially with unicameral bone cysts. There are some out there that do not inject these with methylprednisolone, and they do just as well. Curettage and bone graft or PMMA for reconstruction is used for most active or aggressive benign bone tumors, including giant cell tumor, chondroblastoma, osteoblastoma, chondromyxoid fibroma, aneurysmal bone cyst, and unicameral bone cyst, especially in the proximal femur. However, again, a lot of this is controversial. Sometimes you have to adjunct with a plate and screws. Sometimes you don't do certain things in terms of the adjuvants that you use. So there's a lot more subtlety to it than the simplicity that this breaks it down for. But if you remember that, it'll help get you maybe a question or two on the exam. Wide surgical margins alone are used for sarcomas without effective adjuvant therapy. The classic example of this is chondrosarcoma. It's neither radiation nor chemotherapy sensitive, and so that's the one you've got to cut out. The other ones are going to be low-grade sarcomas. The major benefit of chemotherapy for osteosarcoma and Ewing sarcoma is to reduce the risk of metastases. I crossed out pulmonary because although pulmonary is by far and away the most common, you're just trying to prevent any spread of the disease, really. And it's important to remember that we're not just focusing on the lungs here. Radiation can be used as the definitive method for local control of solitary plasmacytoma, hemangioendothelioma of bone, and Ewing sarcoma, also rhabdomyosarcoma. So you may not necessarily need surgery in those particular things. I crossed out lymphoma of bone because that's now become very controversial with respect to the fact that many lymphomas are so chemotherapy sensitive that you usually would prefer either surgery or some other method, such as just chemotherapy alone, to manage the bone disease. And that's because what we've now seen is these patients' prognosis is so good, they survive so long, that they experience catastrophic problems as a result of their radiation therapy years down the line. Bone fractures, extensive necrosis, needing massive reconstructions and things like that. So it's become much more subtle as to when you do and don't use radiation therapy for lymphoma of bone. Simple excision is chosen for most benign soft tissue tumors, with the exception of extra-abdominal desmoid tumor, which requires wide surgical margins. Again, this is controversial. There are many other adjuvant and neoadjuvant treatments for that, to where many centers don't even operate on extra-abdominal desmoid tumors anymore. So the management of that has become much more controversial. Preoperative radiation for soft tissue sarcomas results in less fibrosis, but a higher risk of earlier wound complications compared with postoperative radiation. So we talked about that earlier, the risks and benefits of pre- and postoperative radiation. Finally, amputation surgery criteria. This is incredibly controversial and very patient-specific and case-by-case, so I'm not even going to bother going over that. However, these are some things where it may be obvious to amputate an extremity and may be tested on, but a lot of it is intuitive. Things like a non-functional limb, multiple recurrences, major resection of neurovascular bundles. There's almost no point in preserving the limb any longer, but again, it's more intuitive than anything you need to learn per se. So that wraps up the general musculoskeletal oncology. And so again, for my Pacific Northwest pride, I'll leave you with this shot of the Three Sisters of the Cascade Mountains looking east coming out of Bend, Oregon. Enjoy, and call, text, email anytime with questions.